This is the third lecture in the series of points of care that I'm giving, and particularly interested in intensive care unit work. I've been working on ITUs in London for 20 years, from the liver failure unit at King's College Hospital to District General intensive care units in Dartford and Queen Elizabeth, and also the large ITU at King's. So it has been an interest of mine. I still do it. I go at least once or twice a week, and I'll show you the sort of cases that I go up to see and how useful ultrasound can be for intensive care patients. So the objectives, we're going to talk about intervention using it for vascular access. Chest ultrasound I've already mentioned. Echo, very useful, echocardiography, looking at the heart on ITU. And then the typical cases that I get to ask to see a patient with renal failure, liver failure and jaundice, chest ultrasounds I've already mentioned, and deep vein thrombosis diagnosis. So let's just talk why we're here talking about point of care ultrasound. Well, in 2000, we were very used to these in the radiology department, very large machines. But in about 2000, Somerset brought out a smaller machine that could be bedside. And instead of having to take this up to ITU, actually physically wheel this up, which I used to do to the liver failure unit, these units were actually on, these small ultrasound machines were actually on the unit. And now we've got high quality ultrasound machines actually on the unit. You just have to go up and then use their machines. And with time, we've evolved even further, got even smaller machines that can be used at the point of care. And I've talked about this before, possibly the butterfly. No, I have no conflict of interest. I have one of these in my office I use. It's on an iPhone, and it can be carried in the pocket, and very useful for diagnosis. The image quality is not quite up to speed with the larger machines, but it can answer some questions. So vascular access, I used to run a vascular access service at King's and also in Dartford, Hickman lines, and also VasCas for patients with renal failure. And here we've got a patient who's in a sterile situation. The operator is gowned up and he's got a linear transducer across the jugular. He's about to insert either local anaesthetic or actually the needle, and you aspirate, insert the wire. And on my website, which I'll talk to you about at the end, I have how to use ultrasound for vascular access. And it's a very simple guide. It shows you the equipment you require, the probe you require. It's a linear probe, how we get the imaging. This again is across the jugular vein. There's the carotid, the jugular's larger, it's more compressible. And then the orientation of the needle probe for vascular access. Now, the real key thing to this is that the center of the image is the center of the probe. So if you have this in the center of your image, and then you put your needle down the center of the probe, you are going to access that vessel. And this is the internal jugular vein. So we'd image it, and then we would insert our needle under ultrasound guidance to the tip of the needle. I personally use it transverse across the vessel. There's the tip of the needle. Aspirate the blood, and you know it's venous blood. And then through the needle, we insert a wire, and then you have a internal jugular vascular access. I personally prefer internal jugular approach because I can compress the vessel, I can access it easily, and generally doesn't cause pneumothorax, which the subclavian approach can do. And it became the gold standard by the National Institute of Clinical Excellence in the UK back in 2002, which is when I wrote this and presented at the British Medical Society of Ultrasound. I also wrote a small book, which is exactly showing the technique for this. There are 250,000 insertions of these a year, and this is essentially a how to do it, ultrasound vascular access. And of course, not only can you use it for vascular access, you can use it for other intervention. Again, I presented this to the British Medical Ultrasound Society. and particularly for draining ascites or any collection, we use ultrasound, demonstrate fluid, which is echo poor. Here's the bowel loops. Again, it's the needle probe orientation, center of the probe, center of the image is center of the probe, insert the needle, aspirate under image guidance, and here's the fluid being aspirated, insert, leave the needle in, insert the wire, and then over the wire introduce our catheter or drain and aspirate. And that's a very safe, simple Seldinger technique for draining either intra-abdominal collections or pleural collections. And this is what I taught the interventionists, the intensivists at Dartmouth Valley or Kent Hospital. To be fair, they're very good at intervention. They just needed to know how to orientate the ultrasound and the image. So how can ultrasound help us with ultrasound of the chest? Well, this is a typical chest X-ray we get on ITU, where the patient is supine and we have loss of the hemidiaphragms here and increased density at the bases. It's not clear whether this is fluid or consolidation. Patient is difficult to ventilate, they're difficult to examine clinically, but ultrasound can be excellent in this situation. And there are three possible outcomes, imaging intracostally at the bases. Either normal lung, and that's what normal lung looks like, highly reflective, no image behind. This is the liver, and that's normal. So this could be normal, and it could just be a radiographic anomaly, or it could be consolidation. Here is the spleen. Here is similar. There's the hemidiaphragm here. This is grey lower lobe consolidation with air bronchograms. These bright branching areas are fluid, air within the bronchi, highly reflective, and that's lower lobe consolidation. Or it can be this scenario where it's actually echo poor and it's fluid, no image. Here's the hemidiaphragm, and these are the ones that we need to differentiate between, because you can insert a drain if they've got difficulty in ventilating and improve their ventilation using the Seldinger technique that I showed you before. Here's the probe, here's the needle, center of the image, center of the probe, and insert the needle, wire, then catheter or drain. I get asked to examine patients with renal failure. Patients obviously on ITU generally have got some sort of failure, respiratory failure, liver failure, renal failure. And basically I'm examining the kidneys to look for obstruction. And this is a case of hydronephrosis, where you have the, what's called the Mickey Mouse ears. These are the calyces. This is the infundibulum, and this is the pelvic calyceal system. And this is an obstructed system. This is a surgical case. If I find these on ITU, I alert them immediately. And because if you drain these, you can actually improve renal function. The majority of kidneys on ITU are not like this, and I think I'll show you some images later. And again, jaundice, liver failure, abnormal LFTs. I'm looking for dilated ducts. So here are the patient with jaundice, and here are the dilated ducts. Generally, this is a surgical case. It means that there's post-hepatic obstruction causing the jaundice, and generally it's a pancreatic or duct problem such as stones or tumor or pancreatic tumor. And ultrasounds and adjunct to the cardiovascular exam can be very useful. A subcostal approach, we can't quite see it here, but there is pericardial effusion. Looking from below, you can exclude a pericardial effusion. You can assess the left ventricular function using a Simpson calculation. So it's end diastolic volume minus end systolic volume over end diastolic volume, and work out the LV function. This is hugely important in ITU. I do it on every patient if I was running ITU, because it tells you whether the lungs, which are white on the chest X-ray, are due to heart failure or RDS. And again, we can use a parasternal view here if we're worried about right heart dysfunction in patients with possible pulmonary emboli. Here we have the half moon of the right heart, and when it's obstructed or dilated, it becomes a full moon, and these are the images we get. And in this case, we'd be thinking about pulmonary outflow obstruction, such as pulmonary emboli. So the ultrasound point of care echo can be extremely helpful on the ITU patient. And deep vein thrombosis imaging, I get asked to examine the deep veins. The leg is swollen. These patients are often on ITU, they're immobilized, and sometimes their legs swell due to immobility. If you think of varicose triad, which are the pathophysiology of deep vein thrombosis or thrombosis anywhere, stasis, vessel wall damage, hypercoagulability. Well, stasis, they can develop deep vein thrombosis, it's stasis of flow. And this is the anatomy that I have in my mind. Here we have the common femoral vein, which is what I look at the groin, and I examine the superficial femoral vein all the way down to the popliteal and at the trifurcation. And this is what I'm looking for. I'm looking for, this is the vessel at the groin. Here's the artery, here's the vein. The vein is larger, and it goes vein, artery, nerve. So the vein is lateral to the artery. And what I want to see is that it's compressible. If it compresses with pressure, it means there's no thrombus in here at all. I can put color flow on, but really it's compression I'm interested in. I also do a spectral trace at this level, at the groin, common femoral vein. And if there's variation with respiration, then it means there's no proximal obstruction. This is an example lower down where you've got actually thrombus within the vein. It's echogenic, it doesn't compress, and this is, look, this is with compression. It doesn't compress because it's full of thrombus. So I examine all the way down the superficial femoral vein, then I go behind the knee, look at the popliteal vein, and then down to the trifurcation. It's more difficult to look at the calf, particularly in patients who are lying down, and particularly often the calves are large. It's difficult to exclude one of these. There's three pairs of veins in the calf, the posterior tibial, anterior tibial, and perineal. But I do try and see if I can see thrombus, but they can be difficult to examine. But these areas are not difficult to examine, so I can exclude a popliteal, trifurcation, superficial femoral vein, and common femoral vein. And with spectral trace, I can exclude a proximal obstruction. So let's have some cases. They've got a 50-year-old man. So let's just apply what I've been talking about to cases and the principles, or the very simple principles I've talked about. 50-year-old man, how can ultrasound help this patient? Well, look at this gentleman here. The lungs are normally black because they're full of air, and they're now white because they're dense, they're full of fluid. The fluid is in the alveolar. This is called airspace shadowing. In the differential for this bilateral airspace shadowing is pulmonary edema secondary to heart failure. If you do an echo and see the heart function or the LV function is normal, then it's not due to heart failure, it's due to RDS or infection. And that's a massive differential. That helps you. I do an echo on every single patient on the unit, because if their lungs turn white, then you know it's RDS and not heart failure. Extremely helpful. So I talked about renal failure, and this is a 70-year-old woman with abnormal renal function. That's why she's on the unit. This is the technique I use, goes quite posterior to the kidneys using a curvilinear probe 3.5. And this is what I'm looking for, the renal anatomy. Now, normal kidneys are between 7 and 12 centimeters. There's normally a renal cortex and a renal medulla, which is bright due to fat. And what I'm looking for is if there is fluid or echo-poor areas within the renal medulla. These are the calyces, the infundibulum, and this is the pelvic calyceal system. This is an obstructed kidney. If it's bilateral, then it's bilateral obstructive uropathy, and that's the cause of the renal failure. That is not a normal, that we don't often find that on ITU patients, to be honest. Normally what we're finding is patients who have sepsis and are hypotensive, and they've got acute tubular necrosis rather than obstruction. But this is why we are looking to make sure, see if there's a reversible obstructive cause of renal failure. So in a man bilateral, we think about obstruction at the level of the prostate with chronic retention. I'd always look at the bladder. And in a female or a male, if the bladder and prostate are normal, if you've got bilateral hydronephrosis, you've got to think about the retroperitoneum. I've seen a case just recently, bilateral hydronephrosis in a gentleman with a normal bladder, no residual when they were catheterized, no significant residual. We did a CT, and there were lymph nodes in the retroperitoneum, and it was malignant retroperitoneal fibrosis or retroperitoneal malignancy causing nipping of the ureters, causing bilateral hydronephrosis. However, that's quite unusual in ITU, but that's why I'm doing the ultrasound. We want to select out these cases where a nephrosity may help these patients. The majority of the patients I see have this appearance. So the kidneys are swollen, they're bright. These are the pyramids, they're quite clear, they're dark, and this is acute tubular necrosis. Slightly swollen kidneys, very bright with these pyramids, no evidence of obstruction. And of course, so that is an acute insult. That's probably due to hypotension and sepsis. There are lots of causes of acute tubular necrosis, including drugs and many other systemic problems. But the commonest cause, certainly in ITU, is hypotension secondary to sepsis. And then sometimes we see this on ITU where you've got very small kidneys. They're about 7 or 6 centimeters with thin cortex. So this is chronic renal impairment, and it's often acute on chronic or just chronic renal impairment. So the renal size can be helpful. This is very different from this swollen kidney and very different from this obstructed kidney. So ultrasound can be very helpful in the renal failure patients or the renal dysfunction patients. Just recently, obviously, we've got this COVID epidemic, and we have had cases where the renal function has deteriorated very suddenly. So often COVID, despite them having a normal blood pressure, can affect the kidneys and produce a creatinine of about 300 to 400. And that's thought to be small vessel disease or microvascular involvement of the kidneys. Due to COVID, it produces avasculitis. You get hepatic dysfunction, you can also get renal dysfunction. But we've had a case where the creatinine shot up very quickly from 300 to 800, very suddenly. And when something happens suddenly, you think it's vascular. We did an ultrasound and it was renal vein thrombosis. So not only microvascular, but large vessel thrombosis. And we're seeing an awful lot of thrombosis in COVID. It is a procoagulant, inflammatory, post-viral disorder. So jaundice or hepatic dysfunction, we do an ultrasound. And the key areas I'm looking for are the ducts. Is there duct dilatation? So this is the portal vein. This is the normal anatomy. This is taken with a 3.5 megahertz probe over looking particularly at the liver hilum. So this is the normal anatomy, the portal vein posterior, the hepatic artery, and the common bile duct, less than 6 or 7 millimeters. If it's dilated like this, in fact larger than the portal vein, if it's over 6 millimeters, 7 millimeters, this is a dilated common bile duct. You have to think that the cause of the liver function, the cause of the abnormality of the liver function is due to obstruction and post-hepatic obstruction, such as stones in the common bile duct or pancreatic tumor. So this again is something to pick up on ITU. We want to know this because this is a surgical case and this is potentially reversible with a stent. Often we just see a normal liver anatomy and normal ducts, and that means it's either cholestatic jaundice or at the level of the liver. Sometimes we see patients who've got signs of chronic liver disease. We see this picture and we see a very dense liver, and we've got an irregular outline, and this is cirrhosis with ascites. The portal vein is it can be thrombosed, and we look at the spleen for signs of portal hypertension, and the ducts are not dilated. So this is a medical cause of a chronic medical cause of liver dysfunction. This is a surgical cause. Often there is no abnormality of the anatomy And it's either a hepatitis or cholestatic jaundice that's causing the problem. So here we have a 45-year-old patient with a swollen leg on ITU on the left leg here, and I've examined the common femoral vein, and so this is the artery here. It's echo poor, and there is a filling defect in the vein which is not compressible. This is a deep vein thrombosis at this level here. So I'd examine here with a curvilinear probe. I'd examine all the way down, but once I see it at here, it's an iliofemoral DVT, and that's really don't need to image any further. So yes, here we have that case of the sudden onset of change in renal function to creatinine 800 in a COVID positive patient. This is what a normal vascularity looks like. Here's the vein, here's the artery, and these kidneys were really swollen, and there was no colour flow whatsoever. On a normal abdominal setting, you'd expect to see colour flow in the vein, and there was none at all, and a diagnosis of renal vein thrombosis. This was bilateral, could be made. So, difficult to ventilate patient. Again, here we are. You've got lost silhouette sign. You've got a hazy density. I did an ultrasound, and there is an effusion on the left. Difficult to ventilate patient. Difficult to examine because they're supine. But ultrasound can examine them very clearly. Here's the hemidiaphragm. Here is the spleen. Send the probe. Send the picture, and then you'd insert a needle here. Aspirate, and then insert a wire, Seldinger technique over the wire, insert a drain. And I've done this several times in ITU where there's actually been a collection in the pleura using ultrasound to guide it in, and we aspirate pus and its empyema. They do occur, and they can occur secondary to chest sepsis. So I really do think that ultrasound is a fantastically exciting diagnostic tool and extension to the clinical exam. And it's not just me that's saying that. The Society of Intensivists in the UK have set up an ultrasound limb and part of their training, and you can see why it can be extremely helpful to turn differentials into diagnosis, which is what I've written here. And the versatility of this imaging tool really has to be seen to be believed, from the eyeball to the testicle to the kidney to the liver. Really quite astonishing information you can get very simply, very quickly, if you know your anatomy and your pathology and you've been trained to do things. And it can be extremely simple, some of the anatomy, and can be just used as a rule in, rule out. And I really think it's got a great future. Well, it's already been used quite extensively in intensive care units, and eventually intensivists will be doing their own ultrasounds in certain areas, and I will be coming up with specialist things like collections, the abdominal pelvis. So yes, really for me, ultrasound never fails to excite. Really enjoy using the imaging tool, really enjoy seeing the anatomy and making difficult diagnoses or very simple. So thank you. And that is ultrasound on ITU. Thank you very much.